دقيقة خليني أشوف. لا، أنا فاتحهن هيهن دقيقة أفتحهن يعني.
يعني افتح انا
ثواني.
واعمل هنا الكبسة النص هاي بتاع مينيمايز للسلايدات على
طيب هاي هسا نعمل. قبل نعمل سلايد شو هاي. طيب هسا فاتحهن، وين الزوم تبعنا؟ هيو شير. يا أخي مش طالع لي شير وايت بورد، دوكيومنتس، فوتوز، مايكروسوفت شير بوينت. شو هذا كله؟ شوف طالع أشياء كثير.
طب دقيقة، دقيقة اشوف من عندي هون.
بدك ابعث لك اياهن؟ بعث لك اياهن.
موجودين عندي بس بدي اشوف كيف اسوي من
لا،
عندي.
في النسخة الأخيرة، خلنا ابعث لك اياها. هاي اللي فاتحها اصلا، بدريش اذا معدل عليها ولا لا.
بتاعت امبارح ولا غيرها؟
خلنا ابعث لك هذول دقيقة احسن، بلاش يكون مش نفسه. دقيقة، ثواني ناصر خليك معي. طيب سند الكوبي. هاي وصل لك، اذا تعملهن شير من عندك.
دقيقة.
طلعن.
اه موجودات.
طيب عملت لهن شير.
دقيقة خلاص بصير من عندي، اه مش مشكلة.
خلص شغل من عندك، مش راضي يطلع من عندي.
طب هيك السلايدات طالعة كاملة؟
طالع، لا مش طالع عندي. طالع
معمولة
سلايدات، طالع شاشة.
ماخذ الشاشة كاملة قصدي ولا
اه
مدها سلايد؟
اه
ماخذ الشاشة كاملة اه.
اه اه.
اه طيب اوكي تمام، خلينا بس دقيقة نعمل ريكورد. جاهزين يقرأ عليها.
طيب ما طلعش سلايدات، بس يطلع دقيقة. مش عارف، انا بعد مبين عندي الشاشة.
دكتور
اه
ناصر
ناصر.
السلايدات مش طالعين سيدي.
مش طالعين
لا
السلايدات؟
لا، بدك تفتح عليها طالع جوجل كروم بس.
طيب بسيطة دقيقة.
ناصر صار شيء.
دقيقة واحدة يلا.
ايوه
هيك مبينات السلايدات.
نفس الشيء، كروم، شاشة الكروم.
شاشة الكروم هيك. طيب
يا أخي مش عارف
القصة دقيقة.
شو قصة الزوم.
هيك طيب.
هيك بلشوا.
هيك بلش. طيب
خلاص اعمل سلايد شو.
وهيك سلايد شو أخذت.
طبعا هسه كيف بدي اصير احرك ولا انت بتحرك؟
خلاص الحركة من عندي.
يلا حرك.
خلاص جاهز تبلش.
يلا. طبعا يعطيكم العافية جميعا واسفين على التأخير. يلا ناصر نيكست. طبعا هاي بس انا كنت راح اعمل كيس ديسكشن، بس بما انها محاضرة ويل سكيب كيس ديسكشن. بس هاي امثلة على كيسز يعني you will see in the clinic as cases of patellar instability. Different presentations, different scenarios. Each case you have to deal with it differently, with different investigations and different treatment. So next slide. So in this lecture, we will talk about what's patellar instability, the epidemiology, the anatomy of the patellofemoral joint, stabilizers for the patellofemoral joint, risk factors for instability, clinical assessment, investigations, and the management. Next, Nasser. So when we talk about patellar instability, it's a spectrum of diseases. It's not the event of instability, it's a spectrum of disease. It can be a subluxation of the patella or frank acute dislocation or chronic patellar instability, which can present as pain or apprehension. In our clinic, we see it in 3% of our knee injuries. It happens, it's common, it's fairly common. It happens in about 6%, in 6 persons per 100,000. Mostly it happen in young age group. If it occurred, it may recur in about 44% of the cases. So it depends on the study and the population which you are studying. So there's a large variation in recurrence rates. It can go from 15% to 44%. When we talk about patellar instability, we have to understand the risk factors which are associated with patellar instability. General factors such as hyperlaxity and neuromuscular disease, and there's also local factors such as ligament injury, trochlear morphology, patellar height, patellar morphology, malalignment, and muscular weakness. Next. To understand patellar instability, we have to understand the patellofemoral joint, the anatomy of the patellofemoral joint. It's a diarthroidal joint composed of two bones, the patella and the femur, but it also involves the knee joint itself and the proximal part of the tibia. So the patella moves in the trochlear groove down to the level of the knee joint. The patella itself is the largest sesamoid bone in the body. It has the thickest articular cartilage, which reflects the joint forces that works on the patellofemoral joint. The patella has two articular facets, the medial and the lateral facets. According to Weiberg et al., who classified the shape of the patella into different shapes based on the shape of the facet of these facets. The other part of the joint is the trochlea, which is part of the distal femur, a trochlear groove, which is part of the distal femur between the medial and the lateral femoral condyles. Next. So this is the free body diagram for the patellofemoral joint, explaining the joint reaction forces of the patellofemoral joint. But the main point here is why we have the patella. Patella increase the mechanical efficiency of the extensor mechanism by 50%. So you need 50% less force to extend your knee. In vitro studies and in vivo studies, patients who have their patella excised, they have increased joint reaction force. You need more force to move your knee, which in turn will damage the patellofemoral joint and increase the risk of osteoarthritis, and also will weaken your extensor mechanism. You need about 40% more force to extend your knee, and you will increase the joint reaction force by 250%, which is a large percentage. Next. When we talk about the patellofemoral joint, we have to understand also beside the joint anatomy, we have to understand the joint motion itself. The patellofemoral joint has a 4D joint motion. It's not just 3D, it's 4D. It works in 3 dimension, but the fourth dimension is time. So we have to know where exactly the patella and the joint to understand what's going on and what's the problem for each patient. Stability and stabilizers of the patellofemoral joints change with time. Sorry, Nasser, if you go back to the slide. So they change with time and with the position of the patella within the trochlear groove. Patella, if you look at the figure, you'll see the patellar contact point changes, and from the patellar entry point down into the trochlea. So at each time, there's different contact point and different joint reaction force and different stabilizers. Next, Nasser. So to understand more the stability of the patellofemoral joint, we have to know what's the stabilizers which are working on this joint to stabilize the patella and the trochlear groove. There's the bone and the soft tissue. The bone itself is the patellar shape, according to Weiberg et al. The trochlear groove morphology and depth, which was explained by DeJour et al. We have to know the anatomical and the mechanical axis of the patellofemoral joint and of the lower limb. We have to understand the term which is called the Q angle, which change with flexion and extension. The soft tissue stabilizers there's two types of tissue stabilizers. We have the static and the dynamic. The static is the MPFL, and we have also other ligaments such as the medial patellotibial ligament. The dynamic, we have the quadriceps muscles, mainly the VMO, which works to stabilize the patella and the groove. Next. The most interesting one of the soft tissue static stabilizer is the MPFL. It lies in the second layer of the knee. It has a fan shape and two bundles, femoral attachment to the medial femoral condyle, distal to the adductor tubercle, and proximal to the superficial MCL fibers, posterior to the medial epicondyle. It has patellar attachment at the junction of the proximal and middle thirds of the superior medial patella. We have to know this anatomy because when we want to reconstruct the restore the patellar instability and reconstruct the MPFL, we will depend on these anatomical landmarks. So there's what we call the shuttle point, which we always have to find on the lateral radiograph, which will give us a close approximation to where the patella attached on the femur, the MPFL attached on the femur. The MPFL provide lateral restraint to the patella between 0 to 30. So this is important because, as we mentioned previously, the patella has different types of stabilizers according to where it is within the joint and according to the time during flexion and extension. So on the first 30 degrees, the MPFL works as a stabilizer. After that, the patella should engage the trochlear groove, and then it will depend more on the bony stabilizers. It's fairly weak ligament. It can withstand up to 200 newtons of tension. So it shouldn't work under high stress and high tension environment because it will fail. And it only works in low tension environment. Next. So let's talk about clinical assessment. When you receive patient who is referred to you with complaint of knee pain or patellofemoral instability, you have to ask in history. You have to ask some relevant questions, such as you have to analyze the dislocation event itself. When did it happen? At which age it happened? How did it happen? Was it a low energy or high energy force that caused the dislocation? How often does this happen? If there was pain, swelling, tenderness, locking, motion restriction, did this affect his gait, his ability to do his sports or his activities of daily living? Then you have also to ask about other joints, which if there's any problem with other joints, such as other joint dislocation or hypermobility of other joints. You have to ask about his past medical history and his past surgical history, if he had any previous injuries, any surgeries to the lower limb or around the knee, if he's on any medications, and family history is important. You have to specifically ask about if other members of his families has same issues with joint dislocation, because this may be a sign of hyperlaxity. Treatment is any treatment he has received, and we ask this history to know what are the risk factors associated with this dislocation, because when we want to plan your next step in the management, it's different if there's if the injury happened in sport athletes or in a patient with hypermobility. Next. The examination, and for me, I always start with examining for hypermobility. I look for the patient while he's moving, walking into the room. I do the Baton score. So it's a graded system a numerical grading system to find if the patient has hyperlaxity, which may cause joint hypermobility. Always don't forget to look from the front, the side, and the back. Look at both lower limbs, compare them together, see if there's any obvious deformity, malalignment, rotational deformity. Then ask the patient to sit down, ask him to extend and flex his knee, see if there's any J sign or signs of patellar instability. Sorry, Nasser, can you go to the next slide? Yeah, so this is the J sign. The J sign is is basically you ask the patient to extend his knee, and usually with patients who has patellar instability, the patella will translate laterally while the patient is extending their knees. This is because it disengaged from the trochlear groove, and now it's free with no static stabilizers or dynamic stabilizers to keep it on track. Always also you have to know what's the range of motion of the patient, because it's important in patient with patellar instability. Some patients may have osteochondral fractures, which may lead to joint locking or decreased range of motion. Next. There's also the examining the patient while he's supine. Always look for effusion. There's different signs of joint effusion. We're not going to talk about them. Ask the patient if he has any point of tenderness. Always palpate for tenderness and crepitus. Ask the patient to move his knee, flex and extend his knee, and do the active and passive range of motion. Then I do the patellar translation, which is called quadrant test. Normally, it should translate less than 2 quadrants. If you divide the patella into quadrants, then the normal is less than 2 quadrants. If the patella translates laterally more than 2 quadrants, this is a sign of patellar instability. Assess the patellar tilt, see if it's asymmetrical on the medial and lateral facets. Assess the patellar height if you can. Sometimes it's not obvious from examination. Assess the bulk of the quadriceps, the VMO. Do the apprehension test, which is flexing the knee while applying lateral force. If the patient has instability, will become apprehensive because the patella will dislocate or subluxate. Always do a neuromuscular assessment and neurovascular assessment because it's very important in patients with patellar instability to, especially if you're planning to do surgical treatment for them, and always compare with the other side. Nasser, can you go to the first slide in the examination? Yeah, the one before that. So there's also some special tests, which is very important when examining patients with patellar instability, such as rotational profile, foot progression angle, and relation of the feet to the patella when the patient is standing. So the rotational profile is very important. We always miss to examine that because it's not the most obvious thing to see. But if there's any rotational abnormalities such as miserable malalignment, this is a risk factor for patellar dislocation. Nasser, can you go to the next slide? No, the one after that. So this is the rotational profile, which has 3 components: the foot progression angle, the medial and lateral rotation, and the foot and the thigh foot angle, and also the the forefoot adductus in pediatric patients. Next. Now we'll talk about investigations for patellofemoral instability. We'll start with radiographs. We need to do long lower limbs films, standing long lower limbs films. The CT scanogram is not accurate because it's not a weight-bearing image. And if you look at the weight-bearing versus the non-weight-bearing, you'll see differences. On the X-ray, we look at the Q angle, which is the angle between the vector of the quadriceps muscle and the patellar tendon. So it's measured by measuring the angle between the line from the anterior superior iliac spine to the center of the patella and the line from the center of the patella to the patellar tuberosity. This angle should be less than 7 degrees, but it's different between males and females, and it can also be different between different populations. So it depends on which study you're reading. You have also to assess the lower limb axis, the mechanical axis, and the anatomical axis. Patients with genovarus and genovalgus, they have different, especially patients with genovalgus, they are at risk of patellar dislocation. Next. For the lateral radiographs, according to the Jur classification, is the most important radiograph to assess the trochlear dysplasia. There's 4 types of trochlear dysplasia. If you go to, can you go to the next slide, Nasser? So according to the Jur, we have A, B, C, and D. Trochlear dysplasia. We have 3 important signs: the crossing sign, the double contour sign, and the trochlear spare. So the crossing sign is a sign of shallowing of the trochlear groove, and the double contour sign is a sign of hypoplasia. And the trochlear spare is just a sorry, سامعني؟
بتحب نحط مؤشر إشي تأشر إشي معين؟
مشكلة أنا الصورة أنا على التليفون مش واضحة. يعني إذا بدنا نحكي
بحاول أطلع لك مؤشر دقيقة. أو مش هون. لا المشكلة مش طالع، أنا آسف. خلاص أوكي.
اوكي، يعني خلينا نحكيهم حكي احنا بس مشان الشباب يفهموهم. هلا احنا بالنسبة للكروسنج ساين it means انه we have a shallow groove but the groove is still there. The double contour sign means that there's a condylar hypoplasia, mostly the medial side, and there's a lateral convexity. So there's no true trochlear groove here. You see 2 shadows on the lateral X-ray, true lateral X-ray. You need true lateral X-ray. The trochlear spare is a sign of trochlear maltracking. You'll see a spare protruding within the trochlear groove. Next. So this is how is an explanation of the Jur classification. It explains it outlines what we have talking about. Next. The other important thing we have to look for in the lateral radiographs is the patellar height. And we have to know why patellar height is important in patellar instability. So if the patella is high, then it will not engage into the right place at the right time. So we talked about the patellofemoral joint stability, and that it's a 4D. It's a 4D. It has a 4D anatomy, which is related to time. So when you have a high riding patella, it will not engage into the trochlear groove at the correct timing. And once it will engage, it may engage in different parts of the trochlear groove that it's not the right place to engage at that right time, and it may put it at risk of dislocation. So the patellar height can be measured on X-ray or on MRI scan. We measure it at 30 degrees of flexion. We have different types of indexes to measure the patellar height, such as the most common one is the instability complex index. Sorry, we have the Catton Dutch maps, and we have the Blackburn Peel. In our practice, we use the instability and the Catton Dutch map because it has this variation. Next. This is also important to see on lateral radiograph, especially during surgery when you are reconstructing the MPFL. It's the shuttle point. So the shuttle point is a point where the line extending from the posterior femoral cortex meets the Blumenstadt line. It will just be anterior to the Blumenstadt line at this crossing. Can you go to the next slide? Sorry, go to the previous slide, to the shuttle point. Yeah, so it would be just 1 millimeter anterior to this point where it crosses the Blumenstadt line. And this point is the most accurate indication on lateral radiograph where does the MPFL originate from on the femur. And we use that to reconstruct the MPFL. Next. We have the merchant view, or the sky or the sunrise view. It's also very important to do that for patients with patellar instability. Usually if patient has patellar instability, it will start at the early stages of flexion. The position of the patella during flexion may be different, so you have to know at which angle to properly take the radiograph. We usually take it at 40 degrees of flexion. What we will see is the lateral patellar tilt. We also look for the sulcus angle, the congruence angle, and the lateral patellofemoral angle, and the patellar shape and morphology. The lateral patellar tilt, which means there's asymmetry between the distance on the medial and lateral sides, and the patella will be tilted laterally, and there'll be more opening medially. This means that either the medial structures are not working well to hold the patella, or the lateral structures are tight, and this is a sign of instability. The sulcus angle, it will measure how deep is the trochlear groove, and normally it will be 135 plus minus 10 degrees. The congruence angle is an angle which measure where the patella, the most posterior part of the patella locates in relation to the deepest part of the trochlea. Well, we don't use it oftenly, but it's an indication for patellar instability. Also, we have to know the Weiberg classification for the patellar morphology. Next. The other investigations that we will do for patients with patellar instability are CT and MRI scans. CT is important, especially in acute dislocations, to look for osteochondral fractures, loose bodies, and also we use it to measure the tibial tuberosity trochlear groove distance, and look for the morphology of the trochlear groove and the patella. MRI, as we know, it's better for soft tissue, so we will see cartilage, if there's any thinning, cartilage damage, or osteoarthritis. If there's any osteochondral fractures, also we use it to measure the tibial tuberosity, trochlear groove distance, and we also use it to measure the tibial tuberosity PCL distance, which is another way to another index for patellar instability. It's also helpful to see if there's any tears in the MPFL, especially at the femoral side, and also will help to know if there's any abnormal patellar height according to the BDR specification and cartilage overlap. Next. So can you go back to the previous slide? Nasser, can you go back to the previous slide, please? So before moving into the management, we have to know, we have to understand these indexes that we are measuring on the CT and on the MRI scan. So the tibial tuberosity trochlear groove distance is an indication how much there's lateral translation force on the patella. So if this distance is more than 20 millimeters, this means that the tibial tuberosity is 20 millimeters lateral to the trochlear groove, which means that the there's a lateral force vector that works on the patella, and this may lead to patellar dislocation. The other method to measure is the tibial tuberosity PCL distance, which also measures this lateral vector, but it concentrates more on the tibia by using the PCL as reference, as the other reference. So if there's any morphology any abnormal morphology or deformities in the trochlear grooves, this will be a good alternative. The BDR classification measures how much overlap is between the patellar cartilage and the femoral cartilage in the trochlear groove. So it measures a ratio, and this ratio indicates how much overlap is there. And if there's a high riding patella or patella baha, then this ratio will change, which means that this overlap is now abnormal, and it could be less or more, which means there's a patella alta or patella baha, and it's very accurate, and it can be measured on an MRI scan. Next. So let's move to the management. And when we manage any patient, we have to, with injury, we have to have goals and aims for this management. So in patellar stability, we aim to restore stability, normal stability and normal tracking, treat any underlying osteochondral damage, and prevent development of osteoarthritis. So we should achieve all these three goals together when we manage patients with patellar instability. Next. So there's different guidelines which talks about patellar instability management to achieve the three goals that we talked about. And because there's different guidelines, this reflects that this is a complex pathology, and there is also a lack of high quality evidence. Most of this evidence are either expert opinion or low evidence with level 3 or 4 evidence. DeJour et al. Has worked on management of patellar instability, and he developed an algorithm which I find useful for these patients. There's also consensus guidelines, which was published by Post and Basque in the UK, based on systemic review of the current literature. But overall, this evidence is also based on, level 3, level 4, and 5 evidence. Next. So this is the Joule algorithm, which he called Minoli Carte, which means, treat everything together. It's a complex algorithm, and it looks into different factors and such as number of dislocation, if there's sorry, let me just hold on, let me just adjust my position. So it looks into the number of dislocations, and if the MPFL is involved, if there's any abnormality in the TT-TG distance, or if there's any abnormality in the height. And according to the jaw, there's a different pathway to treat each patient based on these factors. Next. Basically, we start with conservative treatment, which is the first-line treatment, especially for first-time dislocation. But we have to know that we can't do that if there's any underlying osteochondral fractures and looking symptoms. Always try to avoid prolonged immobilization due to high risk of stiffness. We use patellar brace, which has a hole in the middle to hold it, to keep the patella inside, to allow healing of the soft tissue. Sometimes, if there's a large effusion, you may do arthrocentesis to ease the pain, and then you have to send the patient for physiotherapy to start strengthening of the stabilizer around the knee, such as the VMO, the quadriceps, and also core body strengthening, and also iliotibial band stretching. Always I'll start with closed chain exercise, because the limb will be stable. Then if the patient gain more stability, then I may move him to open chain exercise. The problem with conservative treatment is that there are high rate of free dislocation, and especially with MPFL injuries. Next. Surgical treatment. For patellar instability, we have to have a holistic approach, MDT approach, multidisciplinary, involving the knee surgeons, the physiotherapy, and the occupational therapist, because it's a complex issue, which and we have to deal with all the aspects of this injury. In our hospital, in our service, we do soft tissue reconstruction first. We do arthroscopy to examine the joint. If there's loose bodies, we remove them. Then we will do soft tissue reconstruction, which is mainly the MPFL. If there is chronic instability or there is obvious deformity, then we'll deal with that with bony procedures, such as tibial tuberosity transfer, trochleoplasty, and trochlear groove deepening, and osteotomies around the knee. Each treatment should be the treatment should be tailored according to the underlying pathology and the patient needs. So you may see two patients who has the same problem, but you treat them differently according to their needs and their expectations. If you're dealing with athletic patient, then the treatment will be different than if you're dealing with a hyperlax patient. Avoid doing lateral release. Classically we think that tight lateral structures may be a factor which leads to dislocation. However, if you do a lateral release, then you lose the lateral stabilizers of the patella, which prevent the patella moving laterally, and this may increase the patellar instability. So if you're doing a lateral release, you have to know why you're doing that and how much release do you need to know to do. And if you're doing a release, you need to know also how to reconstruct the lateral structures if this release leads to instability. Next. So this is an example of arthroscopic view of the patellofemoral joint, and you can see the trochlear groove and the patella and both facets. We do the arthroscopy to remove loose bodies, assess the joint, and see how the patella engages into the trochlear groove, and see a real-time visualization of the patellar tracking. But you have to bear in mind that when you inflate the joint, you may alter the patellofemoral joint, and this may give you a false impression about how the patella moves in the trochlea. Next, MPFR reconstruction is the one of the most common surgeries that we do for the patellofemoral joint. We use mainly hamstrings as autograft, but sometimes we use allograft for revision cases. There's no evidence to support which graft is better, so we use gracilis, semitendinosus, any of them. We do a double limb autograft, which has a better outcome. We do anatomical reconstruction under image guidance using the shuttle point. There's two different methods of fixation, which is only شو مثلا نكمل؟
دقيقة أكثر على أسئلة دقيقة بس. خلاص هيك الأمور جاهزة.
نكمل؟
كمل سيدي.
Yeah. So we are talking about onlay versus inlay fixation. There's no evidence to support any of these. If there's any difference in the results, we do both. Each one has its benefits and its drawbacks. So whatever you do, better do it. There's different fixation devices that we use, such as screws in the buttons, anchors, based on the technique that you're doing and your expertise. Severe trochlear dysplasia is the most predictable factor for failure after MPFR reconstruction. So if you're having a patient with severe trochlear dysplasia, you may need to think about trochleoplasty also with the MPFR reconstruction. Next, Nasser. Okay, so this explains the MPFR reconstruction technique. We do it under general spinal anesthesia. Always you have to know your landmarks, bony landmarks and soft tissue landmarks, such as the borders with patella, medial epicondyle, the tibial tuberosity, digital point on the image intensifier, and the joint line. We harvest and prepare the semitendinosus, and we utilize two incision technique, and we prepare the tunnels under image guidance. Next. So again, shuttle point, which we talked about. And also, again, you need to understand the anatomy and the layers. We said that the MPFL is in the second layer, so you have to know which layer you're working in, and you don't need to go to pass the MPFL intra-articularly inside the joint. And next, post-operative rehabilitation, we use gradual range of motion approach, use with adjustable knee brace, and we always send patient for quadriceps strengthening from day one. Next. Trochleoplasty is the other surgery that we do for patients with patellar instability, especially for chronic recurrent patellar instability with severe trochlear dysplasia type B or D, according to the jaw. It's contraindicated when patients have osteoarthritis or open physis, and if there's pain with no instability. We aim to decrease the joint reaction force and improve tracking by deepening the groove and improve the tibial tuberosity trochlear groove distance. It can be done open or arthroscopic, and we do both techniques in our service. Next. So the open technique, described by Dijoux, we remove the spare, we do osteotomies and deepen the groove. You may need to remove fragments, some fragments of the groove to deepen it, but you have to preserve the cartilage cover. We call it subcondylar approach to preserve the cartilage. It's very important. Next. The other method is arthroscopic trochleoplasty. You have to be experienced arthroscopist to do that. You have to raise cartilage flaps and do your debridement under the cartilage, and then refix the flap. The benefit is that it's minimally invasive, and it's quicker to rehabilitate the patient. Next. Tibial tuberosity transfer. Also for recurrent patellar instability with failed conservative treatment, and patients with anterior knee pain and abnormal patellar height and abnormal TT-TG distance. You have to understand the pathoanatomy very well before doing this procedure. It can be done for pain, instability, or both. Always do preoperative planning, and if you fail to plan, then you're planning to fail. There's different types of tibial tuberosity transfer. There's the Falkerson type, which is the anterior medialization. There's the anteriorization, and there's also the medialization and the distalization. Each one of them is used for different pathology. Next. The most common one that we use is the anterior medialization to restore the TT-TG distance, but also you can do it also to restore the patellar height at the same time, and to anteriorize the patella to decrease the joint reaction force in the patellofemoral joint. It depends on the angle of cutting. The more acute angle you do, the more anteriorization you achieve. So you have to plan very well. We will not talk about the details of the surgery, but you have to understand the concept of the osteotomy, the TTT osteotomy. Next. So this is an example of the anteriorization tibial tuberosity osteotomy. So if you look on the images on the diagram, you'll see that they anteriorize the tibial tuberosity about 1 centimeter, which in turn will decrease the joint reaction force and decrease anterior knee pain. Next. The post-operative protocol is non-weight bearing with knee brace, locked-in extension, then gradual range of motion according to patient progression. Quadriceps exercise from day 1, gradual weight bearing at 6 weeks, and gradual range of motion after swelling and pain allows. Next. So the injury, it's the patellofemoral instability and patellofemoral dislocation is a complex injury. There's it's a multifactorial. It has multifactorial causes. So there's no golden option to treat these patients. We know that the MPFL is the main stabilizer for lateral translation, and it is almost injured in all patellar dislocations. Recurrence after conserved treatment with MPFL injury is about 44%. Patellofemoral dislocation after MPFL reconstruction is very low, about 5%. So that's why we always start with MPFL. Success rate can be high as 96% if you do MPFL and tibial tuberosity transfer. So some surgeons advocate doing this for every patient. But in our practice, we do the MPFL first. But there's no golden option, and treatment should be tailored according to the injury and according to the patient. I think we're done, Nasser. Yeah,
Yes,
we're done.
I think yes. Thanks a lot for interesting lecture, Rada.
Yeah, thank you. I try to explain the concepts here rather than the information which you can read from any source such as Orthopedics or Miller for the exam, but you have to understand the concept and why this injury is complex and why there's different types of treatments. And I'm open for questions if anyone would like to ask questions.
دكتور علاء الله يعطيك العافية سيدي.
الله يعافيك.
I have really 2 questions we face in our practice usually. بالعادة بس يجينا مريض acute patellar dislocation. How we deal with this patient? يعني can we acutely do CT scan, when we can do MRI, and when we can transfer the patient for the sport medicine? The second question is a casting have a role?
سؤالك ممتاز. مين السائل؟ بس انا لانه مش طالع عندي.
انا سيدي دكتور عمر طلعنا.
ميت اهلا وسهلا. هذا السؤال بالنسبه للكاستنج. اول شيء على الكاستنج احنا حكينا avoid immobilization because it will lead to stiffness. However, when you are in the emergency department, you don't know if there's a loose body or not. You don't know if the patella has reduced well or not. So, it's preferable not to do more harm. So that's why casting acutely may have a role until we furtherly investigate the injury. So yeah, for me, if you see a patient with an episode of patellar instability, and his knee is swollen and there's a lot of pain, there's no harm in putting the cast and then referring him to the sport clinic on the first coming clinic for further assessment. If there's a loose body inside, then you preserve the knee from further injury. If there's not, it's just a fusion and dislocation, then we will deal with that with, either conservative or surgical treatment. So it's a very important practical question. And yeah, just refer them. If you have a knee dislocation, refer them to the next coming sport clinic. On an urgent basis, you can talk to us, or you can write them a note and refer them. That's both ways are right. Okay.
Okay. Thank you, sir.
Is there anything else I didn't answer?
According to the MRI, when we can do it, and CT scan acutely after 1 week, 2 week, 3.
So we usually do CT scan acutely to look for any osteochondral fractures. But if we're expecting chondral injury, which you can't see clearly on the CT scan, then we do an MRI acutely. So the acute imaging is mainly to look for osteochondral fractures. But if a patient presented to you with chronic dislocation, then the indications, the indication for urgent MRI and CT scan is not clear here. You don't need to do them acutely. You can send them, for appointment to plan your surgery in the future, because it's different when you have a patient with acute knee patellar dislocation with suspected osteochondral fracture, and patient with recurrent dislocation which has been occurring for the last couple of months with no sign of locking or patellar fracture, or no fusion or something like that.
Okay,
Next.
thank you.
Yeah, is there any other questions?
دكتور علاء يعطيك العافية.
الله يعافيك.
Regarding the referral of patients to our clinic, usually first indicator, and as Dr. Alaa mentioned, there is a high probability of this patient being treated conservatively with no recurrence in 50 to 60% of patients. هلا فاحنا for us this is usually treated by اللي هو التيم الهوسبيتال اللي received the patient على الأقلية بالbeginning، بيسوي طبعا assessment تبعهم. إذا تبين إنه في عنده fractures then you can refer him to us عشان نسوي إحنا اللازم. أما إذا ما فيش عنده إشي بس اللهم dislocation you treat him conservatively بالfirst instance، وإذا صار عنده recurrence بتحوله لنا. And usually we don't treat first-time dislocators with pure ligamentous injury. فهذا إيش بس تحطوه ببالكم يعني عشان تكون النوت واضحة والجزء اللي حكاها الدكتور علاء.
صحيح، الله يعطيك العافية دكتور مثنى. يعني the trial of conservative treatment always start at the peripheral hospitals before they are referred to us. But as we said, if there's any patient with suspected osteochondral injuries or fractures, or you're afraid that there may be something that a loose body that is locking the knee, then we are more than happy to discuss that.
يعطيك العافية دكتور أنا شكرا. دكتور عمر واضح الجواب بالنسبة للريفيرال
سيدي واضح، نعم صحيح 100%. الله يعطيك العافية سيدي.
Okay. Are there any other questions?
دكتور علاء الله يعطيك العافية.
الله يعافيك.
أنا دكتور محمد المصطفى. محاضرة جميلة.
هذا دكتور.
أنا بس حبيت أتأكد من شغلة. هلا الحالات اللي بكون في عندهم complete MPFL injury، يعني إحنا بالعادة يعني أنتم نيورو براكتس يعني تعملوا MPFL reconstruction بنفس الوقت التي تي ترانسفير تريبل تي، ولا مثلا بكون في ستيج مانجمنت يعني بالبداية MPFL بعدين التريبل تي؟
هلا احنا يعني our school بالRMS we do MPFL first, soft tissue reconstruction, because we know that it can restore stability in more than 90% of patients. However, if there's an obvious anatomical deformity, such as severe, very high Q angle, or patient with recurrent instability and MPFL, then we'll think about tibial twist transfer. However, we preserve it for refractory cases or chronic cases with obvious deformity and clear indications. It's not like routine surgery for every patient with patellar instability.
هلا during investigations لو كانت التي تي جي distance sorry more than 20 meters.
Yeah, so here we have to go back to the patellofemoral joint stabilizers. So the patella engages the trochlear groove at 30 degrees of flexion. So during this period, the first 0 to 30 degrees, the MPFL will work as a check crane and prevent the patella from subluxing laterally. If this mechanism has failed, then the patella will subluxate laterally. So this patient, for example, with abnormal TT-TG, has been doing well during his life, and then an event happened that leads to MPFL rupture, and then his patella become unstable. Then the best thing to do is to restore the MPFL and reassess. If his patella keep dislocating, then we'll do the TT transfer. But it's not from for first line treatment, for first line surgical treatment, even if it's abnormal. But there's cases, as we said, we have to tailor according to each case, because there's patients with multiple factors such as shallow trochlea, MPFL, and TT-TG distance, which is high, very high, and severe Q angle. Then we may do some kind of radical surgery for these patients to treat all together, according to the according to the JOR algorithm.
تمام. هلا سؤال ثاني، حتى بالاكيوت تروماتيك ديسلوكيشن we treat a patient as مثلا splinting، ولما يخف عمل له MRI ودوكيومنتد انه عنده MPFL complete rupture، حتى نعطيهم chance بالكونزرفتيف، صح؟
Yeah. نعطيهم chance. However, we know that it may fail in 50% of patients. So there's 50% of patients which may become stable because there's other factors which play a role in the patellar stability, such as the VMO and the other ligament static stabilizers, which also works with the MPFL. And the MPFL itself, it may heal, but this, it may heal back if the environment allows, and the patient was, committed to the treatment.
تمام. الله يعطيك العافية. كل الشكر سيدي.
Other question?
Yes, Dr. Ala, regarding this question, Sami asked Muhammad.
Yeah.
Simultaneous tuberosity transfer with MPFL. Usually MPFL surgery, we do it in every case of patellar dislocation. And if we do a tuberosity transfer, we do an MPFL with it. If we do a trochleoplasty, we do an MPFL with it. So MPFL is يعني خلينا نحكي عامل ثابت
mandatory.
يس بكل عمليات الاستابيليتي.
Yes.
But again يعني it's, looking at patella والpatellar instability زي ما حكى الدكتور علاء احنا we have found that cases with anatomical aberrancies which is usually present by 80% of patients with patellar dislocation يعني it has been there for the patient's long life. So what caused the patella to dislocate at that time was the MPFL rupture. So that's why we address it. طبعا مش كل السكولز بتوافق مع هذا الحكي. في ناس بيقول لك we have to address everything if we want to treat the instability. But we've been doing this, practicing it for the last maybe 15 years, and usually the patients that need added procedures are very minimal, a fraction of these patients. MPFL works with most of these guys.
Yes. Okay.
And just
تمام.
one thing to say about patellar instability is the patellar fixed patellar dislocation. Usually patients come to you having a small incident of instability, and the patient has habitual dislocation rather than a patellar or true patellar dislocation. Also, as a treating physician, you should know how to differentiate between these two because the approach is very different.
Yes.
يعني نعم صحيح. هو احنا يعني الهدف من كل هاي المحاضرة انه لما تتعامل مع مريض patellofemoral instability ما تتعامل مع الصور، تتعامل مع المريض نفسه. يعني مريض with painless habitual dislocation, يعني you will harm them if you're going to operate on him doing certain extensive or procedures or complex procedures. But athlete with a single episode of patellar dislocation who is like a jogger or a runner or a football player, then you have to think about taking further steps into doing operative treatment, because the circumstances and the patient's circumstances here are totally different. So if you understand the concepts behind the patellar instability and the concepts behind the treatment and how we are trying to achieve our goals according to patient circumstances, then you will succeed when treating these patients. Otherwise, you may do unnecessary surgery or unnecessary treatment, and the patient may not be satisfied, despite your efforts and doing complex surgery.
Yes.
Yeah.
يعطيك العافية.
يعطيك العافيه دكتور محمد. في شغله ثانيه كمان دكتور علاء حكاها اللي هو موضوع الانسال سلفاتي والباتيلر هايت. يعني ما تتفاجئوا اذا الريبورت اللي مكتوب من الراديولوجيست على الام ار اي قال انه في عنده يعني هاي رايدنج باتيلا because this can also be assist. الدكتور حكى بتفصيل عن كل شيء شو بنستعمله او شو هو الستاندرد اللي بنستعمل فيه every modality of imaging. But again يعني you can assess the patellar height on the MRI using the modified insal Salvati index for example or the Caton de Chambre or whatever. فانتم ما تتفاجئوا اذا مثلا لقيتوا انه بتقرير الام ار اي بيحكي الدكتور يعني اشعه عن موضوع الانسال سلبي.
Yes.
This he did it like in the 70s or I think the 50s maybe. تمام على lateral radiographs. فالفكره الدكتور يعني ما تتفاجئوا اذا الدكتور الاشعه كتب والله انه في عنده الانسال سلفاتي هالقد على الام ار اي. فهذا روتين براكتس اصلا.
Yes. والله سيدي نادر ما يعلقوا يعني شباب الأشعة على هذا الموضوع. بالعادة يعني احنا اطباء العظام اللي نحسبهم خصوصا بالبريف.
Yes, maybe in the periphery, but the musculoskeletal guys usually they mention it because there are many cases of especially the high riding patella, which is commoner than the low riding patella, which is actually important. يعني for us clinically speaking, for knee pain, يعني أنت كدكتور عظام تقدر تلقط patella باها is really far more important, which less common الحمد لله than the high riding patella or the يعني high index insal salvati. فحلو انه كمان كطبيب عظام يكون عارف كيف يقرا الام ار اي ويشوف الشغله هاي. اتس فيري ايزي تو ميجر. طبعا انت الاوبزرفر ريلايبيليتي قليله جدا، لانه بتعرف الام ار اي لما ياخذ كاتس بالساجيتال طول الباتيلا بيختلف، فبدك تعرف انت كيف تاسست يعني تقريبا طريقه صح. آه، واحسن شيء حكاه الدكتور علاء اللي هو البيدرت اندكس حاليا بالنسبه كمان في ديجور اندكس، هو نفس هم اثنيناتهم يعني. على الام ار اي بتشوف الاوفرلاب بتوين اللي هو الكارتج تبع الباتيلا والتروكلير كارتلج، فهذا كثير كمان بفيدك على السريع في الدكتور يعني انه هل في مشكله ولا لا. اذا كان I think like less than 12.5 percent contact او 7 ملم الكت اوف. ففرصه تطلعوا عليك اخصائيين موجودين بالبرايفت سوري بالبريفري، وتشوف شو بالضبط كيف وضع الباتيلا. يعني سهل جدا تقرا عنه. البيدرت اندكس حكى عنه الدكتور علاء كثير مهم، وهسه كثير يستعمل في موضوع الاسسمنت للباتيلر هايت.
يعني الله يعطيك العافيه دكتور مثنى. يعني حتى بتذكر قبل اسبوعين تناقشنا بحاله، وكان البيدرت اندكس يعني هو الفيصل بموضوع الميجرمنت، لانه يعني بعطيك يعني accurate guidance how much is the patellar height على MRI scan. ناصر سامعني؟ الو.
سامعك.
راح الصوت لانه فجأة اختفى. يلا.
طيب
آه
نعطيك على
سؤال لناصر كونه الان بالنمسا، how do they approach patellar instability؟
actually the same approach sir. يعني regarding the surgery, same steps as we do, and regarding physical examination and symptoms, as discussed in this lecture, they assess symptoms of feeling of instability and pain. Examination, same exam, uh, hyperlaxity and J sign, lateral translation. And regarding the surgery, they prepare the medial patellar aspects to put two anchors in the proximal and middle parts of the patella, and they use the X-ray to assess the shuttle point, and they use the two-limb graft as an onlay procedure.
Do you see them do any other further يعني surgeries or they start with an MPFL؟
They start with MPFL. في يعني حضرت معاهم امبارح MPFL. في بشوفهم بيسووا سيرجريز في بالتبروسي ترانسفير، بس ما حضرتش حالي معهم لحد الآن. التروكليوبلاستي ما شفتهم حاطين إشي لحد الآن عليها.
يا سيدي الله يعطيك العافيه.
الله يعافيك باشا.
enjoy your fellowship.
تسلم سيدي. هلا باشا، يعطيكم العافية جميعا.